This is Dr. Chitra, your mentor at Study Medic and Study MRCOG. And Part 2 MRCOG exams are around the corner again. So we are back to you with our RRR series in an effort to help you to clear this exam. Today we would be discussing important flowcharts and diagrams from maternal medicine module. We normally begin all our sessions or our series, YouTube series, with a positive or a motivational quote for all of you. Remember, time is something that is non-refundable, so spend it really very wisely. In today's session or in this video, we are going to be seeing important flowcharts from chickenpox, obstetric cholestasis, GBS infection, venous thromboembolism, and sepsis. The concept is that there are a lot of flowcharts or diagrams that are there in the guidelines, and we want to discuss these with you. So let us first begin with chickenpox. Okay. The commonest questions would be asked is like for which woman would you offer her post-exposure prophylaxis, or what would be the risk to the baby of developing fetal varicella syndrome? When would you deliver the baby if the mother has contracted infection during pregnancy? So you have this lady here at 16 weeks of pregnancy. She has come to the GP with rash and fever. She has a small child at home who is diagnosed with chickenpox, and the woman herself has no history of having chickenpox herself as a child. So she is now worried as to what would be the effect of this infection on the unborn child, assuming that it is chickenpox. So how are you going to counsel her? Okay, so there could be no risk of infection. There is a small risk, that is less than 1% risk of fetal varicella syndrome, or high risk of fetal varicella syndrome, likely to have a spontaneous miscarriage, or it will lead to intrauterine fetal death. The answer here is there is a small risk of fetal varicella syndrome. How do I know this? For this, you should be knowing this algorithm. Okay, the important change that has been done here is that previously any woman who has been exposed to someone having chickenpox and she herself has not had chickenpox as a child, or she has not been vaccinated, or on investigation it has been shown that she doesn't have antibodies to chickenpox, then for these women we were giving immunoglobulins. The change that has been done here is that instead of immunoglobulins, they have started given acyclovir as post-exposure prophylaxis. Immunoglobulin will be given only if there is a contraindication to any viral therapy, or there is an adverse effect, or the woman is allergic to this acyclovir. Only then immunoglobulins would be given. Okay, the rest of the chart, nothing has changed. So any woman who has had a past history or who herself has been given the chickenpox vaccine as a child, for her, even if she is exposed to someone with chickenpox, there is no risk to her or to the unborn fetus. Women, those who have come with an uncertain history or no past history, then for them you will test whether she has antibodies. If antibodies are present, then she does not need anything. You just reassure her. If antibodies are present but the titer is less than 100, then for them you will give acyclovir. If there is a contraindication to acyclovir, you will give immunoglobulin. Now, even after giving acyclovir or immunoglobulin, if the woman develops chickenpox, okay, then for her you will advise her to avoid contact with other potential contacts. That means anyone who's pregnant, or avoid contact with neonates. Okay, she should be isolated. You will give her symptomatic treatment. You will admit her in the hospital, and you can give her acyclovir once she has been given once before contact. But if she develops chickenpox in spite of giving post-exposure prophylaxis, you can again repeat for her acyclovir. Okay. If the woman has severe infection, Remember, severe infection in pregnancy, the woman needs to be hospitalized to prevent complications. If she is in the later part of the pregnancy, avoid a delivery at least for a period of 7 days since the appearance of the rash. And if this infection happens at less than 28 weeks of gestation, inform her that the risk of developing fetal varicella syndrome is like usually less than 1%. You will refer her to the fetal medicine specialist at around 16 to 20 weeks of pregnancy or 5 weeks after the development of the rash, so that an amniocentesis can be done and you can detect fetal varicella DNA in the amniotic fluid. The next important one is about venous thromboembolism. So here it's very important to know the score, how you are going to calculate the score. So I would advise you to pause the video, read the question very carefully and come to an answer. So here the answer is basically this woman has a score of 3 and she needs thromboprophylaxis from 28 weeks of pregnancy. So how did I come to this? For this, you have to be knowing this chart. Okay, here you have to know the antenatal risk factors. See, the ones that are given in red, those are very high risk factors. That means she has had a previous venous thromboembolism except one that is a single event related to major surgery. If it is related to major surgery, it is not so high risk. So anyone who has a high risk factor, for them, like in the first trimester itself, it's a score of 4 and they will immediately start low molecular weight heparin as thromboprophylaxis. Now, intermediate risk factors, those who have intermediate risk factors, for them usually if the score is 3, you will start from 28 weeks. If there are 4 or more risk factors, you will start from the first trimester itself. Okay, and women, those who have less than 3 risk factors in pregnancy, for them, we do not start low molecular weight heparin. Instead, we advise them that they should not become dehydrated and they should have adequate mobilization. They should ambulate themselves frequently. So all these risk factors you should be aware of. Read this chart very carefully. It should go on your study wall and it should be pit pat for you. Okay. Now next is again like in the postpartum period. So remember this venous thromboembol, the risk assessment that you will do at booking, you will do at 28 weeks and again you will do in the postpartum period. So for this woman here, because she is preterm, okay, she has delivered at around 36 weeks of pregnancy, her age is more than 35, okay. So for her, she is having 2 risk factors. You will give her at least for a period of 7 to 10 days. We do not have the option of 7 days. So I chose the option that is here for 10 days. And remember, it is prophylactic. It will not be therapeutic. Now, this is the postpartum assessment. Like I told you previously, anyone in the postpartum period, 2 or more than 2, they will be given thromboprophylaxis prophylactically. Those who have high risk factors, that means those who are on low molecular weight heparin from 28 weeks of pregnancy, for them usually we give them for a period of 6 weeks in the postpartum period. Those who have intermediate risk factors, they are given for a period of at least 7 to 10 days. If the risk factors are persisting or there are more than 3 risk factors, then you can consider it to be given for a period of 6 weeks. Okay, so these are again all the risk factors that you have to be aware of. Now the next is you should be knowing about the risk factors that are transient. So remember hyperemesis or ovarian hyperstimulation. For these women, the thromboprophylaxis is given only till the risk factor is present. Once the risk factor is no longer there, then you will not give them thromboprophylaxis. So ovarian hyperstimulation, it usually resolves by the end of the first trimester. Till then, it is a risk factor. It has a score of 4. So for these women, you will give thromboprophylaxis only till the end of first trimester. If there are other risk factors, then you will continue it again after the first trimester. So here you can see that there are some risk factors which have a score of 4. Those are marked in red. The amber ones are intermediate. They are marked as 3, and the yellow ones are low risk factors, so they are marked as 4. Now OHSS, even though it has a score of 4 and it is marked in red, it is a transient risk factor. So anyone with OHSS, you will not continue for OHSS itself, you will not continue thromboprophylaxis till the end of pregnancy. It will be given only till the end of first trimester. Okay. The next important thing that you have to know is about the doses. It's very important to know. The important thing that you have to keep in mind is that you will calculate the dose based on the booking weight or early pregnancy weight or pre-booking weight. You will not calculate the dose based on her current weight. So to confuse you, they will give you her current weight at 28 or 30 weeks of pregnancy or later in pregnancy, and they will also give you her pre-booking or the booking weight and calculate the dose of low molecular weight heparin. Remember, always calculate the dose based on her pre-booking weight. Okay, so here her weight at booking was 66 kg. So the dose for her is 40 milligrams per day. How do I know this? It is based on this chart. So you should be knowing the doses of enoxaparin, dalteparin and tinzaparin. And for thromboprophylactic doses, the weight of the woman, it is divided as someone who is less than 50 kg, 50 to 90, 91 to 130, 131 to 170, or someone more than 170. So again here, this is about the prophylactic dose. So a woman who has presented with signs and symptoms of pulmonary embolism, she is weighing 100 kgs at booking. Now her weight is 115. So you will consider her weight as 100 kg and then calculate the dose of they have asked here the dose of dalteparin, and remember here now it is the therapeutic dose. Therapeutic dose is something which is different from the thromboprophylactic dose. So for her she needs 100 milligram twice daily. So these are the doses of enoxaparin and dalteparin. Tinzaparin is very easy because it is 175 units per kg once daily, whatever is the weight of the woman. And for therapeutic doses, remember the weight is less than 50 kg, 50 to 69, 70 to 89, 90 to 109, 110 to 125 or more than 125. So please read the question very carefully, whether it is therapeutic dose or prophylactic dose, and read what is the weight that is given. Always use booking weight or early pregnancy weight, not the current weight of the woman. Alright. Now next, coming to management of acute thrombosis or embolism during pregnancy. So you should be aware of how the woman is presenting, what are the investigations that you would be doing, and what is the next investigation to be done. So before starting low molecular weight heparin, a minimum of chest X-ray, ECG, full blood count, U's and coagulation profile has to be done. Only then you will decide, or then you can start low molecular weight heparin. And if the woman has signs and symptoms of DVT in her lower limbs, then you will order a compression duplex ultrasound of the lower limb. So if that suggests that a DVT is present, there is no need to go ahead and do a VQ scan or a CTPA. Because if a DVT is already present and the woman presents with signs and symptoms of pulmonary embolism, just go ahead and treat the pulmonary embolism because it is a life-threatening condition. Okay, and most of the times this DVT that is there, it has thrown a thrombus and it has gone and lodged in the pulmonary circulation. So here this woman, because she has signs and symptoms of DVT in her lower limbs, you will do compression duplex ultrasound of the lower limb. If she doesn't have any of these signs and symptoms, or if this compression duplex ultrasound of the lower limb, it does not show that there is DVT, okay, then what will you do? So you will go back to her X-ray chest. If X-ray chest is normal, then you will do a VQ scan for her, because the VQ scan will show whether perfusion is normal or abnormal. If perfusion is abnormal, that means one of the lung is, or a part of the lung is not being perfused properly. Yes, there is some obstruction and it is likely a pulmonary embolism. If the X-ray chest is abnormal, then you will go ahead and do a CTPA, because that CTPA, it will show you more in detail what is the likely abnormality, whether it is a pulmonary embolism, whether it is a bronchiectasis, it is atelectasis, or it is some sort of infection that is there. Okay. Now, if pulmonary embolism is not confirmed at all, then what do you do? Okay, so if the suspicion of pulmonary embolism is very high, remember it is a life-threatening condition, so just continue to give low molecular weight heparin. But when the suspicion of pulmonary embolism is low, you can discontinue low molecular weight heparin. Okay, and you can come to consider some other diagnosis. So this is basically the algorithm that is given in the guideline, and I hope I am like the guideline, the algorithm is clear to all of you now. Okay. Next is about knowing the doses of unfractionated heparin. So women who need unfractionated heparin, for them, remember that APTT is kept between 1.5 to 2.5. The loading dose of unfractionated heparin that is given is 80 units per kg, and then the maintenance dose is 18 unit per kg per hour. So they will give you what is the APTT at present, and then according to that you have to modify the dose of unfractionated heparin, whether you want to increase or you want to decrease. So here her APTT is 1.4. APTT is 1.4 means the woman has not been heparinized adequately. You need to increase her dose. So for her, you will give her a repeat bolus of 40 units per kg, increase the infusion rate by 2 units per kg per hour, and remember that whenever you change the dose of unfractionated heparin, you will repeat APTT ratio after 6 hours. So this is the algorithm in detail. Okay. Now next, coming to obstetric cholestasis. So this is another guideline which is an updated one. So remember to follow this. So intrahepatic cholestasis of pregnancy, remember women will present to you with itching. But the criteria is that if there is any skin change, then this is not considered to be intrahepatic cholestasis of pregnancy. You will think of some alternative diagnosis. If the skin is normal, okay, then you will check her bile acids and you will check the liver function test. So if bile acid is less than 19 micromoles, then it is considered to be gestational pruritus, and for here this woman there is no increased risk of stillbirth or anything, but depending on how she progresses, you might consider repeating her bile acids again depending on the severity of her symptoms. Now bile acid, depending on the bile acid concentration, whether it is, when it is 19 to 39, it is considered as mild form of IHCP. When it is more than 40 to 99, it is moderate, and anything more than 100, it is severe IHCP. So severe IHCP, why we are very concerned is because there is a risk of stillbirth. So after 35 to 36 weeks of pregnancy, there is an increased risk of stillbirth in these women, and they require extra care. So what is the criteria to diagnose IHCP? Bile acids more than 19 and skin appearance is normal. How will you diagnose in the postnatal period? So 4 weeks after the woman has delivered, the itching should have been resolved and LFTs and bile acids should return to normal. What is the concentration of bile acids after which there is increased risk of stillbirth? So in a singleton pregnancy, obviously, so anything more than 100, or women who have severe intrahepatic cholestasis of pregnancy. Important change regarding the treatment. So remember here that none of the treatment offered decreases the risk of stillbirth. Okay, that means the pregnancy outcome is not improved. For maternal itching, what is the treatment? Now it is not ursodeoxycholic acid. You will offer her topical emollients and antihistamines, especially if the itching is disturbing her sleep at night. Any role of vitamin K? Only if the woman has steatorrhea or the prothrombin time is abnormal. Mode of birth, it is usual obstetric practice. You will not offer her a cesarean section simply because she has intrahepatic cholestasis of pregnancy. What will you advise in the future pregnancy? There is definitely an increased risk of recurrence. So LFTs and bile acids should be checked at booking. So this is in short the management plan. Remember, for women, those who have mild, you will deliver them by 40 weeks of pregnancy. Those who have moderate IHCP, they will have a planned birth at 38 to 39 weeks of pregnancy. And those who have severe IHCP, for them, you will deliver them by 35 to 36 weeks of pregnancy. Ursodeoxycholic acid has no impact on the stillbirth, and nowadays it is not routinely offered to anyone who has IHCP. Additional liver investigations are usually not done unless the clinical picture is something abnormal or atypical. That means very early onset in pregnancy, or if the liver function is markedly abnormal, the woman has jaundice, fever, or someone in whom normally we expect that in the postpartum period all the signs and symptoms should resolve. So for women in whom this resolution does not occur, for them you will offer additional investigations. So these are a few questions that I've made for you. Pause the video and then afterwards think of the answers, and afterwards when you click you will get all the answers. Now coming to GBS. So remember here that the type of questions that would be asked is basically for women who are going to be offered intrapartum antibiotic prophylaxis. So GBS affects the fetus, and we want to give intrapartum antibiotic prophylaxis to prevent early onset GBS in the fetus. So whenever you are doing a cesarean section, like a planned cesarean section for any woman who is having previous to LSCS, or the woman is not in labor, membranes are intact, irrespective of whether she is a GBS carrier or not, or if unfortunately she has had an intrauterine fetal death, then for these ladies there is no need to offer intrapartum antibiotic prophylaxis. Okay. Now coming to other women. So remember that any woman who previously had an infant with invasive GBS disease, irrespective of what is her status now, you will offer her intrapartum antibiotic prophylaxis. Any woman in preterm labor, irrespective of her GBS status, she has to be given intrapartum antibiotic prophylaxis. Now, GBS carriage has been identified in a previous pregnancy. So, explain to this woman of the likelihood that in this pregnancy also she would be still carrying the bacteria. So, you can offer her intrapartum antibiotic prophylaxis, or you can offer her testing 3 to 5 weeks prior to her expected date of delivery. So normally at around 35 to 37 weeks of pregnancy, you can retest her again and see whether she is still a carrier of GBS. If she is still, then you can offer her antibiotic prophylaxis. Now women, those who are term, okay, so if there is pre-labor rupture of membranes, that is PROM, if she is a known GBS carrier, however she has been detected, you will immediately give her intrapartum antibiotic prophylaxis. You will induce labor as soon as reasonably prophylaxis. Now, if it is unknown what is her status or she is negative, then for these women, there is no need to give intrapartum antibiotic prophylaxis. But remember, these women are at term. Okay. Now, any woman who is in labor, so if there is no risk factor for early onset GBS in the baby, no need to give intrapartum antibiotic prophylaxis. Any woman who has pyrexia in labor, that means a fever of more than 38 degrees, you will give her broad spectrum antibiotics, and these antibiotics have to be the ones that would be effective against group B bacteria also. Any woman who has had GBS carriage in this pregnancy, however it might be detected, for these women also offer IAP, that is intrapartum antibiotic prophylaxis. Now, what about women, those who have GBS bacteriuria in this current pregnancy? So, for these women, at whatever time the bacteriuria has been detected in this pregnancy, you will give them oral antibiotics to prevent urinary tract infection. And remember, for these women, that you will always offer intrapartum antibiotic prophylaxis. Even though she had bacteria earlier on in her pregnancy, the bacteriuria has already been treated. Remember to give her intrapartum antibiotic prophylaxis. So these are a few other questions about how you are going to, like the type of questions that are going to be there. Any woman with a full-term pregnancy, GBS status is unknown, but she has come with pre-labor rupture of membranes. For her, no need to give intrapartum antibiotic prophylaxis because she is a term pregnancy. 34 weeks of pregnancy in labor, she is a primey. You don't know about her status, but because she is preterm, you will offer her intrapartum antibiotic prophylaxis. A woman with a previous infant with invasive GBS disease. Now she is for elective CS. So membranes have not been ruptured because it is elective. So for her also, no need to offer her intrapartum antibiotic prophylaxis because she is for elective CS. Woman who has come with an intrauterine fetal death, she had bacteriuria at 34 weeks of pregnancy. Remember, the fetus is already dead, so there is no need to give intrapartum antibiotic prophylaxis. You have a primary full-term pregnancy. She has premature rupture of membranes and she is a known GBS carrier. What will you do for her? For her, because she is a known carrier, you will give her intrapartum antibiotic prophylaxis and induce labor as soon as possible. No role of waiting for labor to start by itself. Okay. The next guideline, important one that has been updated now, is the one on sepsis. Okay, so a few things that are very important. You have to know which women are at an increased risk of developing sepsis in the antenatal or in the postpartum period. So obesity, diabetes, iron deficiency anemia, age more than 35 years, uh, immunity is impaired, or she is on some immunosuppressant medication like steroids for a long time, ethnic minorities like Bami, Black Asian, and other minorities. If she has any cardiac, renal, or liver disease, she has previous history of pelvic infection, she is in contact with someone who has gas, that was invasive gas disease, or she is an intravenous drug user. All these women are at a very high risk of developing sepsis. What about some obstetric factors? So, prolonged rupture of membranes, any woman who is undergoing a cesarean birth, any vaginal trauma, that means she has undergone a forceps or a vacuum delivery, she has had a perineal trauma, retained pregnancy tissue, no matter if it is an abortion or if it is a retained placenta, any invasive procedures that she is undergoing, amniocentesis or chorionic villus sampling, any woman with multiple gestation, or someone who has undergone a cervical cerclage. Remember, any one factor of this places the woman at a very high risk of sepsis, and you should be very alert to all these factors. Now, the next important change that has been there here is the organisms that cause um, sepsis. So previously, it wasn't E. coli, but the recent search it shows that E. coli has emerged as the organism which causes sepsis in majority of women. It is almost 37.3%. Other organisms that have been implicated are group B hemolytic streptococcus, that is GBS, anaerobes Staphylococcus aureus, group A hemolytic streptococcus, that is gas, coliforms other than E. coli, Haemophilus influenzae, and very sometimes rarely Listeria monocytogenes. Now coming to the diagnosis of sepsis. So the things that have been changed here are they have now put in something called as red flag and amber flag symptoms. So which are the red flag symptoms? The GCS is less than 15 or the woman is not alert. That means there is any objective evidence of altered mental state. Respiratory rate more than or equal to 25, that means the woman is hyperventilating. Her oxygen saturation is less than 94% at room air. She has tachycardia or a pulse rate of more than 130 beats per minute. Blood pressure is showing hypotension, that is systolic less than 90 millimeters of mercury, or um, some affection of the renal system, that means urine output. If she has not passed urine for a period of more than 12 hours, or if she has been catheterized, then the urine output is only 0.5 ml per kg per hour. Okay, so these are the red flag signs. You have to be very much alert. Next is amber flag. So here, in addition to having behavioral or mental status, now this amber flag signs or features that are there um, in any woman with suspected sepsis. So this indicates that it is a moderate risk. These are moderate risk factors, but anyway, you have to have a senior clinical review within 1 hour of seeing the patient, okay, or as soon as possible in the community. So which are these amber flag symptoms? Red flag means immediately the woman has to be seen by a senior person. Acute deterioration in functional ability, respiratory rate between 21 to, so these are signs and symptoms which are less moderately severe than what we had in the red flag signs. Okay, so heart rate between 100 to 130, systolic BP between 91 to 100. For red flag it was systolic less than 100. Urine output is almost the same, not passed urine for about 12 hours, or if she has been catheterized, then output is only 0.5 to 1 ml per kg per hour. Any invasive procedures that have been done in the last 6 weeks. So any woman who's coming to you in the postpartum period has undergone a cesarean birth or an assisted vaginal birth, she has undergone surgical management of miscarriage, she has undergone a cerclage, or any invasive procedures like a chorionic villus sampling, amniocentesis, termination of pregnancy. So anything of these invasive procedures. Um, she has an impaired immune system. Okay, so any illness, medication, she's on oral steroids, temperature, either she has fever, that means a temperature of more than 38, or she's cold and clammy, a temperature of less than 36. Some medical conditions like she is diabetic or she has had GDM and she is in close contact with someone who has gas infection, scarlet fever or tonsillitis. So anyone with prolonged rupture of membranes, or there is prolonged vaginal bleeding and abdominal pain in the postpartum period, or offensive vaginal discharge. So anything you see, any even one of this, and you are suspecting that the woman has sepsis, please get an urgent review done within 1 hour of the patient coming to the hospital. Now, this is something known as the sepsis 6 bundle. So, first of all, you will be putting the patient, the first one is the sepsis screening tool acute assessment. So, you will put this patient on a news chart, okay, and you would like to find out whether this could be due to an infection. So you have to find out what is the source of infection. Common sources of infection usually could be in the respiratory system, it could be in the central nervous system, urinary tract is something which is a very other common source. If she has undergone some surgical procedures, then if she has any open wound on the skin, or some other uh, risk factor that you are able to find out, or in any indwelling devices like any woman who is prolonged catheterization, or she is having some central venous catheter or something, this could be infection. um, so you have to look out basically for the source of infection. Then you have to look out for the red flag symptoms that we already saw previously. And if you see even one red flag symptom, then immediately you will start the sepsis 6 bundle. If any amber flag symptom is there, then you will get a senior review done. Okay, now this sepsis 6 bundle that is there, um, you will complete all these actions within 1 hour. So you have to make sure that a senior clinician attends immediately. You will start oxygen, you will obtain an IV access, take blood, start IV fluids, start antibiotics, and monitor the patient at least on a Meo's chart. Okay, so um, what are the things that you would be doing in the first hour? You have to measure lactate levels, because remember, lactate levels would tell you about the degree of tissue perfusion. So if there is hypoperfusion, it indicates that it is severe sepsis, or if lactate is more than 2 or more than 4, indicates severe sepsis. Okay, so the first thing that you would do is measure lactate levels. You will obtain blood cultures before starting antibiotics, but that does not mean that you will delay antibiotics. Obtain the cultures and immediately start broad spectrum antibiotics. Give IV fluids to maintain perfusion. So 30 ml per kg of crystalloids for hypotension, or if the lactate level is more than or equal to 4 millimoles per liter. Now, vasopressors you will give if there is hypotension during or after fluid resuscitation. Then you will start vasopressors to maintain the mean arterial pressure more than or equal to 65 millimeters of mercury. Now, this is the same chart that was there in the previous guidelines also, but this is the antibiotic spectra that is given for all the commonly used antibiotics. So how are you going to read this chart? So remember, the gray boxes that are there, they indicate the spectrum against which organisms this antibiotic is sensitive. Okay, so they have given you anaerobes, you have MRSA, then you have gram positive, staph, strepto, and you have the gram negative organisms, that is coliforms and pseudomonas. Now if you take the first antibiotic, gentamicin, you will see that it is effective against MRSA and Staphylococcus aureus and against gram negative, but genta doesn't act against streptococcus. Okay, group A or group B, none of the streptococcus it will act. Then coming to penicillin. So penicillin, some of the anaerobes it will act on, and penicillin is very good against group A and group B streptococcus. So these are the only organisms against which it will act. So in this way, you will read the chart and you will know what is the spectrum of action of each of the antibiotics. So these are the important charts that you should be aware of. So please go through the charts in detail. And thank you very much for watching the video. I hope it was useful to all of you. And good luck to you for all your for the exams. And I hope all of you rock the exams. Okay. Good luck once more, and thank you so much for watching. Bye bye and take care.